Hello everyone, good afternoon. I hope everyone's enjoying their lunch. My name is Anshul Kumar and I am a rising second year medical student at Morehouse School of Medicine. And I have the pleasure of introducing Dr. Keisha Callins. Dr. Callins is a Georgia-trained physician and a public health professional. An OBGYN with community healthcare systems, she is committed to providing healthcare services to rural and underserved areas in Middle Georgia, with practices in Twiggs and Jones counties. Dr. Callins, the Joe McCann Endowed Professor, also serves on the faculty as a clinical professor at the School of Medicine in the Department of Community Medicine, a department she previously chaired. Dr. Callins is the immediate past chair of the National Advisory Council for the National Health Service Corps and a former National Health Service Corps scholar. She has participated in several leadership opportunities such as Leadership Georgia, Georgia Physicians Leadership Academy, and the CHAMPS Transformational Healthcare Leadership Fellowship at Morehouse School of Medicine. She mentors numerous undergraduate and graduate students, medical students, residents, nurses, nurse practitioners, physician assistants, and midwife students. She has co-authored numerous publications and has presented to a variety of audiences that range from rural churches to a congressional caucus. She is actively involved in pipeline mentorship, translational research, legislative advocacy, and community engagement. Her personal mission statement is, "You may not be able to change the world, but you can change the world of everyone with whom you interact." Please welcome Dr. Keisha Callins.
Good afternoon, everyone. That's not going to work. Let's try again. Good afternoon, everyone. All right, so the good thing is, and I had prepared this whole speech because I was going to get you in your postprandial state, but you're still eating, so I probably have a chance of no one falling asleep on us today. So I am just honored and excited to be here. We've had such an outstanding program this morning. And I believe that we could probably sit here and chat and learn and talk for hours and hours, but I don't think they will let us do that unless we probably order dinner. So I want to spend some time kind of moving forward with the program, and I wanted to say thank you to our staff from the Rural Innovation Center who have put together a fantastic program. I'm super, super excited to have our students here in the Maternal Observership Program. That's the future of medicine. And when we think about how we're going to make differences, it's really about engaging as many of our students looking into women's health and maternal health. I have to tell you that I'm very proud of Joy, and I can call her Joy, not Dr. Baker. Just watching her present and her enthusiasm and her engagement. I'm dating myself because I was her chief resident, but it really is so amazing to see that. And I will tell you that when it comes to making a difference, I think everyone in here can think about someone that has impacted them in a positive way and encourage them in their careers in whatever field that you're doing, and being able to receive it and then pour it back into someone else. And so we have a shared mentor, Dr. Nachabe, who with so many other people that have poured into us, and so we want to really continue that. And when we are energetic and enthusiastic, that spills over into the care that we have for our patients as well. And so really just wanted to acknowledge all the contributing help that we receive to do the work that we do. This is an important platform because in particular, we're focusing on rural health. And no disrespect, but a lot of things are concentrated in Atlanta, Macon, Columbus, Savannah, Athens, and Augusta. But there's a lot of stuff in between. And when we look at the graph that demonstrates the number of OBGYNs that we have, it doesn't look very good in terms of the distribution. So the fancy term we use is maldistribution. And I want to be very careful about including our nurse practitioners or nurses or midwives and all of our lactation consultants and childbirth educators and all the people that really can be involved in care. And doulas especially. We don't utilize them enough, and we need to be incorporating every potential person that can help. Someone asked earlier about ideas for how we really make a difference, and we'll get to that later. I will steal my own thunder. But if we camped out outside the nail salon and the lash salons, we could probably reach a lot of people. So I want us, as we go forward, to think about not how we get more people to come to us, but where do we go to find them? That's really important. June is a very important month. A year ago, we had a pretty big decision with a reversal that impacted a lot of women across the nation. And I spoke to someone recently that asked, what did that mean and how has that impacted your practice? And I will tell you that June of last year, Community Healthcare Systems, we did our first mobile unit on site at the Brookdale Resource Center, which is here in Macon. It's a facility for unhoused individuals who have a chance to stay there. We showed up with that van and we were able to do GYN visits on site and provide birth control options. Now just imagine being unhoused and then worried about a potential pregnancy. And believe it or not, half of the people that we saw had health insurance, but because they were displaced, didn't have transportation, they couldn't access care. So I don't want you to think that it's just poverty that's presenting in that way. It really happens in a lot of different avenues. And so it was very, I think, ironic that just when that decision happened, we were able to be on site and able to give women the opportunity to have some reproductive control. And if they were in an unpredictable situation, they could still not get pregnant. And that's a big deal. And so I tell my patients all the time, I want you to get pregnant when you're ready. Now, sometimes I don't agree with them when they think they're ready. And so that's where that preconception counseling comes in. And I had a couple of comments on the last question was about how receptive are women to preconception counseling. Well, unfortunately, the way that a lot of women access care is through Medicaid, and they access that when they're already pregnant. And so the culture has not prioritized us making connections with a provider ahead of time or a clinician. And so I do a lot of preconception counseling, and my girls are very open because the reproductive part is only one part of what we can do for women, right? I mean, we can talk about why you keep getting razor bumps or acne or weight. There's so many things that really impact our life. And so the visit or having a relationship with a clinician is the way that we establish that. And then if we need to address that, we can. Vaccine is a good conversation to have. Promoting the HPV vaccine where appropriate now that we have an extension for age. And so again, our systems have to change to reflect the care that we want women to receive. We're not there yet, but if we keep shouting and working together, we will definitely get there. So I want to stay on task because I know we have limited time. The title I selected was, I think, very intentional. What really matters and why it's not just how you start, but how you finish. And the truth is, not everybody's going to enter the prenatal care point at the ideal time, okay? By the time we see most women, most of the important things have probably already occurred. They're happening between, the first 8 weeks. And so, by the time they are establishing care for however long that takes, we've already missed the boat on that. And so I think the preconception portion is so important so women can really be proactive about how they establish that. I have nothing to disclose. And I wanted to start out with something positive, which Dr. Baker did bring up earlier. Georgia is one of now several states who have made this huge move to really extend coverage for the postpartum period. And so we're now calling it the 4th trimester. But I want you to stretch your brain because it's not just 3 months, we're going for the whole year. And why is that important? I believe about a little bit more than a third of the maternal deaths happen in the first 6 weeks, but the majority of them happen in the first year. So just because they survive the 6 months does not mean they're going to be alive at the end of that year. And so we now have an infrastructure that will support that. The challenge is, however, we have to encourage our patients, our friends, our families, our sisters, our aunties, godmothers, I could keep going, to utilize the resources that we have. We have it, but are we having it? Do we have lines of people coming in for postpartum checks? Not yet. Should we? Yes. And so we have a responsibility to really promote that. Everyone knows that maternal deaths are on the rise, and it drives me absolutely crazy when I see the terrible stories online. But I want to let you know that if you're planning to have a baby, you do not have to move outside the state of Georgia, okay? We just have to work on you finding a provider that you feel comfortable with that can help. And so I want to address that as well. As an overview, we're going to talk about the 4 trimesters. I'm going to briefly run through some of the expected things that we do and all of that. And I realize that we have a lot of different people from a lot of different sectors. And so this information is for your clientele, but it may be for your family. And so it really is a learning opportunity. And I believe the information will be made available later on, so that way if it feels like you're getting overloaded, you can go back and look at everything. We'll spend most of our talk really talking about facing the unexpected, overcoming challenges, which I know we had a question earlier about what it looks like to practice in rural communities. And so we'll have that conversation, how to really find opportunities to celebrate in the midst of all the crazy things happening in the world. Opportunities for engagement, utilizing our resources, and then respectful care, which Dr. Baker also mentioned. So again, the screen is really small, and I really wanted to have this here, not so much that we have to read everything right now, but just for it to be a resource. But what things are really happening in the first trimester. Barriers to care, I'm going to pick that out. Unstable housing. That's an opportunity where the first time that you're making contact for that prenatal visit, you want to assess where they are. Why is that? We want to be able to tackle resources. And so one of the things that I made a couple of notes. First of all, everybody needs to make a new friend. And so you're probably sitting with people that you already know. So I would encourage you on our break to cross the room and just say, hey, can I have your number? I don't know what you do yet, but I'm going to get to know you. So we really do need to know all the resources, and no one person knows that. And so we have to be very intentional. When I meet people, I'll nicely say, do you mind if I have your cell number? I promise I won't abuse it. I have numbers for lots of people. And so when things come across regarding my patients, I can pick up the phone and I can make that call. And so we all can do the same thing. That's not unique to just being in obstetrics per se, but you want yourself and your staff to become a walking directory for resources. And one of the things that I know I talked to Ms. Glenda about doing is really finding a way to making sure all of our information is shared, of course with your permission, so that we can start to build that directory. There's amazing things happening across the state, but I didn't know about the postpartum warriors, and I was like, oh, I gotta talk to her. And so really, that's my one friend, by the way, so you all have to find your new friend. But we really have a lot to offer, and so this is important because you need to be able to pick up the phone and make that call. I had a patient that delivered about a year ago who was in a trailer home, and she had no electricity that we found out later, and I don't think she had any running water. She didn't have any food. And so we had to make some phone calls. We were able to find a local church who was able to donate a food box for her, and we were able to get things worked out. But you have to already know kind of what's going on. And if you don't know, you got to know who to call so you can make that happen for your patients. So when it comes to the rural platform, we do have to work a little bit harder, but that network is not impossible to build. When it comes to housing, of course, that can be sometimes challenging, but again, it's knowing what resources are available. In addition, the intimate partner violence is a very important question to ask, and it can be uncomfortable to show up at the doctor's office. You may be getting a pap smear, so you may not have all your clothes on, you feel vulnerable, and then you have people asking you really nosy questions about things that you really don't want to talk about. And so I will encourage you to take a moment to connect with your patient. I heard a beautiful quote that says, change happens at the speed of trust. You have to connect with them first before you go deep and start opening their boxes. So this particular patient came in, and I was getting ready to do her pap smear, and she had a pretty nice sized gash on her leg that was healing. And I said, gosh, where'd you get this? She said, oh, a dog bit me. And I thought, I don't know a lot about dog bites, but that does not look like a dog bite. What really happened? She got really quiet. And I actually stood up, kind of covered her legs back up, and I said, what happened here? And she then told me that her boyfriend threw a glass pitcher at her, and it broke on her leg, and that's how she got that cut. So I was in Albany at the time. I work with Albany Area Primary Health Care. We have I'm blanking on the name now of the crisis center, but we called them. And they came and they got her out of the building through the back door. They went and picked up her child from school before school was out so the partner would not find out. And they were able to rehome her. Okay? So she didn't come in and say, I'm getting beat upside the head. I just saw the gash on her leg. And so what I want you to do in every encounter where you're with your women, you're doing a full body scan. You look at their scalp, look at their nails, their toenails, look at bruises. Where'd you get that? What happened? And with a lot of my younger girls, I'll just say, is your boyfriend beating you upside the head? And they should go, no, that's not happening. But every now and then you get a response that's not like that. And so you want to incorporate those conversations into every single thing that you do. Of course, asking about alcohol, tobacco abuse, depression, anxiety. I have a lot of women who have been on medication for some kind of mood disorder, and then they self-discontinue because they think it may be harmful to the unborn child. Now, there are some medications that we would prefer that they would not be exposed to. However, a lot of the medicines are usually in what we call category C, where if the benefits outweigh the risk, we can continue. And so your question may not be, what meds are you taking? Your question may be, what meds did you used to take, and when did you stop taking them? And you might find that they stopped taking their Zoloft, which is perfectly fine, but they can still continue. And so really, the way that you ask the question and kind of what you have in mind is very important because you want to try your best not to be judgmental, but you do need more information so you can do the right thing to help them. So just a couple of things on there. Desire for pregnancy, I think is a touchy question, but it's important. The circumstances under which everyone gets pregnant is not always ideal. We talked about before 50% of pregnancies being unplanned. But I have patients who were condom users and it didn't work, or there was a break in the condom or something. And so there are people who have really been trying to do the right thing and it did not work. And so they bring that uncertainty or surprise or stress with them into pregnancy, and that is going to impact what happens to the baby. And so again, just being very sensitive to that as much as possible. And keeping in mind, the things that I'm referring to may not all come out in the first visit. They don't know you yet, number one. Number two, your previous provider or clinician may not have been very kind. And so they may be a little, not nice to you, but it's important not to be offended by that because you don't know what happened before they saw you. And so be very careful about being reactive. And it's easy to, people are just, they answer you like yes or no, and they don't want to talk anymore. And you're like, well, fine, let me just get through this. But, you may need to pivot for a second. Do you have a dog? Did you watch the Braves game last night? Just get them to kind of settle down, and then you can circle back around and do that. And that, again, needs to happen really with every interaction that you have. The writing is even smaller here, and I do apologize. But again, this is for you to go back and review later. Childbirth classes. I know that with the pandemic, a lot of things were on hold, but education is extremely important. Of course, we can do a lot of things online, but some people do prefer in person. So you may find out from them, do you want to do childbirth classes? Do you have a support person that can go with you? How would you like to do that? Do you want to do it in person? Do you want to do it online? Let me show you some resources. But a lot of times we just have to ask the question about what people's preferences are so we can help them. One of the things that I really love is dental referrals. Dental care is extremely important for pregnancy, and that's something that gets missed a lot. Most women are going to have access to coverage for dental services, and so that's something you want to address, because if they get a tooth abscess when they're pregnant, it is a nightmare because nobody wants to really touch them. And so usually we do have to sign a form giving the dentist permission to proceed with care. When I worked in Albany, we had a dentist come in once a week and offer services to our pregnant women, so they could just come in for the visit and they could get their dental screening and their cleaning and do whatever needs to be done. But getting a tooth pulled when you're pregnant is just not fun. And so, when they smile, look at their teeth. You want to say something, when was the last time you had your teeth cleaned? Let me go ahead and set up that referral. But your first trimester, if you are fortunate enough to get your patient that early, it's a great opportunity to do that. And I do realize you may be limited in the services that you can offer, but again, it comes back to resources. So I'm currently now in Central Georgia. I have an email list with all of the places where you can get different services. What schools, dental hygiene schools there are, what they do, how much they cost, how much it costs to get a tooth pulled. And so I have an email for just about everything, but that's one of my emails. And so for your community, you want to find out where are all the dentists and make sure that all your pregnant women, at least during that time, and now we have the postpartum period, can have access to that. Weight gain counseling is important. Dr. Baker addressed that, so I'm not going to review, but really it's important to find out what people's expectations are. Pregnancy does make you a little bit hungry, or a lot hungry, and usually it's not hungry for the right things. And so really giving people education on that. The extra calorie requirement is really equivalent to probably an extra banana and yogurt a day, not a whole extra chicken. And so it really is important to talk to people about their diet, what they're eating, making safe choices. Also talking to them about their consumption of processed foods in terms of like sandwich meat, what kind of fish they're eating to make sure they're making the right choices. Having some resources that you can refer them to that are reliable. And I want to take a moment just to mention here, we talk a lot about social media. Social media can be very helpful. It's a great opportunity to really educate, but it can also be a little harmful. And so you want to know what your patients know. So you can't be anti-TikTok. You have to know what they're seeing so you can detox the things that are not correct. And so again, give your patients an opportunity to tell you what they heard. Well, what'd you see about this? Or, what do you think about this? And then you can address that. When it comes to contraception, which we talk about later, I have a lot of patients who will say, well, I don't want X because I saw this happen. And so you want to find out, well, why don't you want something? Or who told you that? Or where did your information come from? And so as an educator, which we all are, you have to know what people's thoughts are so you can correct them if appropriate. So first trimester. Fetal testing, this is usually where we can do screening for abnormalities, blood tests that can be helpful, and also setting up for an ultrasound. Sometimes, because people are not entering the healthcare system early enough, we sometimes have later ultrasounds that can impact our dating. But definitely this is a time where if you're seeing them in the first 6 to 10 weeks, it's a great time to get a dating ultrasound so that you can kind of get correct dates. So I want to give credit to this question. We had a speaker at the recent Mercer Medical School graduation, and he talked about, people stopping you on the side of the road and saying, oh, my toe hurts, what should I do? And even if you're an OBGYN, you still get questions about toes and ears, but anyhow. So the perspective he was offering is being in the healthcare field and taking care of patients in whatever capacity. Are you going to be bothered or honored? When people ask you a question, you get to choose how you respond. And because you are a source of information, we should opt to feel honored to be able to share information. And it's not always convenient sometimes when you're being asked a question or you're trying to get out of the room when you're seeing a patient and you've been in there for 20 minutes and they have one more question, but they trust you. And so really I would encourage us to all take that on. Now this becomes very challenging in our rural community because a lot of times the complexity of care and the patients that we encounter are just a little bit different sometimes. They may not have access to the healthcare system previously and now they're pregnant, plus they have all the things that were going on with them. And so it can be overwhelming. I want to encourage you and us all to really just start somewhere, make a list and work down it. You don't have to solve everything in the first visit. What most patients want is to know that you hear them, you're acknowledging their concerns, and then you can work on it. So today we're going to work on the broken toenail, and then when you come back, we're going to work on your ears. And they can respect that, And sometimes too, I'll just ask patients, which thing is bothering you the most today? Let's work on that. So allow your patients to be a partner in the care along with you. Second trimester, really looking at your substance abuse. This is huge when it comes to tobacco smoking. And really, do not ever miss an opportunity to encourage your patients to quit. It really does have a lot of long-term impact. And I usually guilt trip my moms and I say, you want to do what's best for your baby, so do it for the baby, which usually they respond very well to that. Everyone should know the number 1-800-QUIT-NOW. Usually what I do is I'll have patients, I said, pull your phone out. Either I'll have them give me their phone or I'll have them dial the number, put it on speaker, make sure they have the right contact. I said the call is going to take 20 minutes. I want you to call this number so you can get some free patches or free gum before you come back to see me next time. I've had one patient who kept putting me off, and while I was doing her pap smear, I know this is wrong, but I had her call them and put them on speaker, and I made her do the call with me in the room. So I've been known to do crazy things like that. But you have to hold your patients accountable, and they need to know that you really care. And most of the time, you can get through to them, honestly. Depression, anxiety is a really big component. I feel like post-pandemic, I can use that word now, I think, safely. The two most common things that I've seen have been anxiety and abnormal bleeding. And if we're half fallen apart, you're completely fell apart by now. And if you're not, you're coming apart at the seams. And so really addressing that, I wanted to go in, we talked about intimate partner violence, but really talking to patients about the therapy, which Dr. Baker mentioned, and then of course sometimes medical therapy is necessary. But a lot of people have these cultural, and I see it across the board, I have a very diverse population, and people are just scared to get on medicine. They think they're going to get hooked on it, think it's going to be harmful, they're not going to be able to get off. And so usually the way I present medication or medical therapy, I'll tell patients, you can walk from here to Atlanta, or you can take a car, you can take an Uber. You're going to get there, but it's going to take you a lot longer. So using therapy or medication sometimes can help you get there faster. And it's just like using crutches. When your foot hurts, you use the crutches. When they don't hurt, you put them down. So you may not need medical therapy the entire time. But if your mood is impacting you to the point where you cannot function, you cannot do the things you need to do, or you think you may be harmful to yourself or others, then that's important as well. It's also a good time to really talk about extensions of care, whether that be lactation consultation, whether that be access to doulas or other support personnel that can be helpful to you. The nice thing is people now have a lot of choices about how they can have their birth, and I think that's appropriate as long as it's safe, but education is important, and so that's an opportunity for you to start having that conversation as well. And the reason I think that the support person is so important is we just have so many unfortunate outcomes. And as Dr. Baker mentioned, the pregnant woman is like trying to labor and push. They may not be able to advocate for themselves. So sometimes having someone in the room with them can be helpful. Good time to start talking about your postpartum care planning. I love this quote, and I have to tell you that there's a post office on College Street, not too far from here. And Mr. Harold is my post office friend. I have friends everywhere, I told you that I do. When I walk in, he starts making my boxes for me and like VIP treatment. So he has a quote up every week, and sometimes he'll get off track and I'll go in and I was like, you have the same quote, what's going on? He'll go to the back and get a new one. But this is one of the quotes that he had, and I love it because it says, "Don't let anyone who hasn't been in your shoes tell you how to tie your laces." And a lot of our patients, we could never imagine or conceptualize the things that they have experienced or are experiencing. And so, I heard sometimes other clinicians say, oh, this patient's just non-compliant. There's always a reason for the choices that are being made. They may not be good choices or good reasons, but it's important for us to understand where people are coming from. I had a patient once who I needed to do her glucose screen, and she was adamant that taking the bottle of orange drink was harmful to her and it was not a good idea. And I said, okay. I said, what sweet things do you like? And she said, well, I love jelly beans. So I looked up online, and believe it or not, there's a type of jelly bean where if you take a certain number, it is equivalent to the glucola test. And I said, do you like these jelly beans? She's like, yeah. I said, well, when you come back, just bring 10 of them. We're going to do your test and we're going to get it done. She was like, okay, I can do that. So it wasn't a complete no. She just did not want to do it that way. The beauty of Google, you can Google just about everything. So my point is, you really, Twizzlers, that's a throw out there. So when patients are giving you a hard time about things, we really have to take a chance to understand what's going on with them, and it will make a difference. So listen and learn from your patients. Third trimester is a big time because things start to get interesting. A lot of times this is where things start to emerge, where we have to screen patients a little bit more. And I want to take a second to talk about the model that we have. So typically you get seen, every month for the first 28 weeks. Then it's every 2 weeks, and then you go to every week after the third 36 weeks. The problem with that is when it comes to our high-risk patients and our outcomes, that model may not work. And I really feel sometimes like we're using a square, but we have like a round peg. And so I want you to be open-minded about how you adjust your prenatal profile to monitor patients who are at high risk. And as we mentioned before, the recommendation now is not to wait 6 weeks to see a patient. It's really supposed to happen within 2 to 3 weeks, depending on what's going on with the patient. So really start to look at that. If the patient is interested in having a trial of labor after having a previous C-section, provided that's something that the hospital has a capacity to handle, that's a good time to have that conversation. Also, if the patient is considering having permanent sterilization, it's important to go ahead and do that counseling and have that paperwork signed. And I tell my patients when I counsel about sterilization, signing the paper does not mean it has to happen. It's just in place in the event that you do. And patients really do need to be sure. It's also a great time to talk about long-acting reversible contraceptive options and making sure that you're understanding their concerns about what may happen. The IUD gets a really bad rep, but it really is a very good birth control for the right person. And the nice thing about IUDs I will throw out there is the bleeding profile that you can get. So not having a period is like awesome, in my opinion. And so I try to tell my ladies, how can we improve your quality of life? We don't have to just cover not having babies, but what else can we do? So just really how you have that conversation is really important. Talking about whether or not they plan to have their baby boy circumcised. I put on here, I kind of stuffed the vaccines on here because really we should be offering the Tdap vaccines right about 28 weeks. And that's something that needs to be convenient. So if you have a practice where you don't stock it, how can you work with that so it happens? Having a pregnant woman make an extra stop, out of their way outside your office to do something that's important may be an issue. And so being able to have a relationship, for example, with the local health department where you have a day where all your pregnant women can go in and get their Tdap, and the family members should be getting that too if they're interested. So thinking about that. Of course, offering the flu shot when we have the flu season is in order. Really looking at our fetal monitoring, mentioning to moms, I usually tell my moms to make sure the baby is kicking at least 6 times in each hour. If you don't feel the baby move, get up, walk around, drink some juice. If you don't feel anything, don't call the office. Don't call labor delivery. Come in. It is much better to come in and be evaluated and be sent home than to sit at home and not do anything. I had a patient who was diabetic. She was 32 weeks. She had been coming in to get tested or fetal monitoring twice a week, and she didn't feel the baby move. I think it was on a Saturday, and she didn't come in. She came Tuesday for an appointment, and her baby was dead. Worst delivery is to deliver an 8-pound baby that is not alive. Worst thing ever. And so really encouraging your patients to come in, get checked. I'll send you home. I won't be offended. The staff will be fine, but we would do anything to prevent an outcome that could be potentially preventable. And so that's also important. Labor signs, this is kind of funny because I see this a lot with my first-time moms where they get tired of being pregnant. And for anyone that has taken care of pregnant women or has been pregnant, it gets tiring. So I was 41 weeks and 2 days with my first pregnancy, and it was just, that was something. So I'm very sensitive about how uncomfortable it can be. But really encouraging women to really be looking at those signs, and they can't just opt out because they're tired. Like if you're baking the bread, you can't end the bread at 30 minutes when it needs to be 45. It will not be right. So same analogy works here. It's a good time to talk about feeding the baby. And I'm very careful about how you say that because people do have the right to choose. Do I prefer that you breastfeed? Absolutely. For as long as you can. If you can do it for 1 month or 2 weeks or 1 year or 2 years, then that's the thing. But that conversation should not happen after the woman is tired from pushing the babies out right here. Are you going to breast or bottle feed? And they're like, whatever. So really planting that seed earlier. And I want to talk about the importance of history. Dr. Baker did a great job of talking about history. But we have a lot more women who may have had breast reductions or some kind of breast augmentation or surgery, which is impacting the anatomy of the breast. So their breastfeeding experience, they're probably going to need some help. And so that is something where the pre-planning is important. So you want to ask about that so you can make sure they have the right resources because it may be a little bit more challenging. Probably 50 years ago, and I'm going to say 50, we had a different kind of community where you had your grandmother with you and you had your aunts. A lot of us are not where we grew up anymore. And so you have to build a village where you are, and you have to have people around you that can really support that process. And so when it comes to breastfeeding, that is a big task. For a lot of women, it is easy. For a lot of other women, it's not. And if we want our women to be committed to feeding baby that way, then we have to be able to make that work for them. Also, when it comes to transitioning later, when they go back to work, being able to set up having access to a breast pump, having access to a safe place in their place of employment so they can breastfeed, really having an environment where that's acceptable. Those are conversations that need to really happen second and third trimester. We don't want to wait till the baby gets here and then that's when we're trying to talk about it. So really, we have a lot of opportunity. And to speak to that question before about time, there's a lot of things that dictate what we have time to do. But remember, it's not just the job of the person who's seeing the patient. The MA who's checking the patient and do vitals can be asking the patient, hey, do you want some help with the breastfeeding? Let me tell you what's available. So really sharing or distributing that job is something that I think we need to get comfortable with so that we can utilize all of our available resources. Talking about postpartum depression, is the mom is on medicine, do we need to make any changes on her medicine afterwards? That's a conversation that needs to happen ahead of time. I love this quote. How wonderful it is that nobody need wait a single moment before starting to improve the world. Everybody here is committed to improving the lives of their patients. And my philosophy is when moms dazzle, everybody shines. So anything we can do to make our moms do better, it's going to benefit everyone, right? Benefit our babies. So the fourth trimester, which is where a lot of our focus is going to be for the remainder of the presentation, is something that we are really paying more attention to because we know the mortality happens in that first year. That first appointment really should happen within the first 3 weeks. At Liberty Regional, if moms have preeclampsia or any kind of elevated blood pressures, they see their OBGYN in 7 days and they see the cardiologist in 14 days. So what resources can you develop in your community where you have that same kind of access? Now I know, depending on how remote or rural you are, you may not have that immediate access, but we do have a lot of opportunities for telemedicine, and that's where you have to get your friends on the line and you say, hey, I have this patient, I'm concerned, where can I send this person to, or having that built in. So really just kind of planning. And just because you're in a rural community doesn't mean that your patients can't have the level of quality of care that they need. Am I correct? It's hard, but we can do that. And so now I'm going to have you repeat after me because I like Simon Says. My patient's healthcare will not be dictated by my zip code. That's the philosophy. And so if we have to go to the moon, which is not that hard to do now, to get what we need to do better for our patients, is that what we need to do. And so hopefully this conversation that we have is the beginning of how we connect the dots and how we really kind of utilize those resources. So that first year, we want to be talking about mental health. There was a lot of discussion about that this morning, and really making sure we're utilizing our resources. I wanted to introduce the concept, and if you get a chance later to Google the Barkin Index, Dr. Jennifer Barkin is actually on faculty with the community medicine department, and she's developed a scale that you can use to assess patients, because a lot of our moms, they don't want to jump off the bridge. They may want to hurt their partner, but homicidal intervention, that's debatable. But they're overwhelmed. They love their kids, they want to take care of their kids, but they're tired. And so the Barkin Index is a way to really assess maternal functioning, and it gives you an opportunity to direct your efforts. Maybe there's been a change in job and she needs food. So how do we connect them with the local markets? A lot of our local markets, we have a market here, they can use their SNAP benefits to get fresh vegetables and to get meats. So how are we really empowering our patients? And I say all the time, we have a lot of resources, but people are not using everything they have access to. And that's because we don't know everything they have access to. And so we have a responsibility to know what is available and what is out there so we can make those appropriate connections. So I'm going to keep going because we have a little bit more to talk about. So actually, I'm going to move forward because I want to talk about the other stuff, transition to care. This was referenced earlier. A lot of our women did not have the opportunity to have preconception counseling. They have medical issues that are not being managed, and those things don't magically disappear because they've had that baby. And we want to have the healthy moms so they can take care of their baby, right? If our moms are not well, they're not going to read to their kids like we want them to. And this morning, that first presentation, I wrote it down, 90% of brain development before kindergarten. It's kind of scary, right? And so we need healthy moms so that way we can get that brain development to happen appropriately. And so really making the appropriate referrals is something that we need to address. And now that we have the extension of our resources in terms of coverage, we really need to be encouraging our moms and have a platform for how they can access that. So I like butterflies. My computer, my laptop, the thing that my patients see when I'm on it is a picture of butterflies. And that's because, butterflies don't get to be pretty by just kind of having someone open that cocoon so they can get out. They struggle. And it's important for us to remind our ladies and our guys too that those struggles can actually yield something beautiful. And so I really want you to keep that analogy in mind. I'm going to spend the rest of the time that we have talking about facing the unexpected. So it is not uncommon. The last time I took call, I had 2 patients come in, literally no prenatal care, advanced dilation, just screaming and hollering. It was quite exciting. I knew it was a full moon even before I looked it up because I thought this has got to be a full moon, and it was. So that makes things interesting. You have to move very quickly. They show up, you got to get to your lab so you can do the things that are appropriate, make sure you're screening, and your pediatricians want to know, do they have any exposure? We now have mandates for checking for syphilis and HIV, especially 3rd trimester, and so really being able to act quickly. So those situations do come up a lot. And then late prenatal care, they may have had 1 ultrasound, that's all you're working with, and again, you're trying your best to assess what needs to happen. So getting really good about doing a complete history and doing that very quickly is important. But the benefit here so much, especially for the woman who is not, for whatever reason, established prenatal care, what are we going to do after the baby comes out? And so all is not lost, right? Remember I talked about it's not how you start, it's how you finish. So once you identify some of those reasons or problems or resources or barriers, really being able to make those connections before they leave the hospital. And the birth control conversation is really important here because a lot of women will say, well, I really wanted to get my tubes tied, but they didn't come in before, they don't have the paperwork. You can sign that paperwork with them on labor and delivery, and you can set up their follow-up. But if your hospital allows, you can do an Explanade in the hospital before they go. I mean, I've done IUDs for my C-sections. So there's a lot of things that we can do. We just have to really be able to address the needs of our women, even if they have not done the things we expected them to do for whatever reason. Miscarriage, difficult part of pregnancy. Not all pregnancies work as we expect. And it's unfortunate that not enough attention is given to women who have had a loss. Whether they've had a loss at 6 weeks or 6 months, it's still very painful. And so there really needs to be some care taken with how we take care of our women. Going back to work 2 days after, not really ideal. I tell my ladies, you know what? I don't want you to do a baby shower for at least 3 months. Don't do it. You're not ready to do it. Just really being careful about whether or not they were planning on being pregnant. And most of the time, even if they were not planning on being pregnant, they're disappointed. And so they may be thinking, well, does that mean I can't get pregnant again? Let me go ahead and get pregnant right away. But that was not their initial intention. So being able to connect with them on that emotional component is very important. The other thing that happens with miscarriages is a lot of women will think that they did something wrong and that's why that happened. So really being able to help to educate them if there's testing that needs to happen to plan for future pregnancies, that's an important opportunity. Stillbirth, I mentioned, that's an unfortunate part that does happen. And we do have that happen sometimes, and a lot of times we don't have a reason for why it occurred, and it is very traumatic for the family. And so really being sensitive to how you manage those patients, how you discuss birth control. If they come into your clinic, where you place them, are they going to be in a room with other women who are pregnant? Really being sensitive to that is important. Sometimes, we have an unfortunate diagnosis. For example, the screening test is then confirmed and they have Down syndrome. How do we manage those moms? What do we do differently? How do we have them have impact or access to resources? I read an article this week that referenced a family that was told that their son would have Down syndrome, and she was just saying how she didn't want pity. She just wanted people to be happy that she had a child. And her child would have some challenges, but it was not the end of the world. So I'm sure there are probably a lot of people in here who have children that may have special needs. And so really how we create that environment of support is extremely important. Preterm labor is a really big concern. especially in our rural communities, because sometimes our women have symptoms and they may be waiting at home or not sure, and when they come in, we may or may not be able to intervene. It's kind of funny because sometimes when you're on call, and Dr. Baker can attest to this, people say, well, how many babies did you deliver? And I said, well, I don't measure my work on the number of deliveries. I measure it on how many I keep from coming out prematurely. So that is just as valuable. But really thinking about what needs to happen, we do have women who have to get a cerclage sometimes. That's where they have to put a stitch in the cervix to kind of keep baby in. Sometimes we have to do bed rest. So sometimes the pregnancy is not all joy. It can be some pain. And really how we support our women is very important, and how that impacts the family dynamic. If they have small kids at home, if they were working at McDonald's and doing their shifts and now they can't work, things look very different. And so how we engage those patients when they come in is very important, because sometimes life can be, not sometimes, life is often very challenging. Care coordination. That is one of the things that I probably, if I asked you to take something away from the conversation today, is care coordination. How do we connect our patients to the services they need? We have to know what's out there so that we can do that well. Transportation is a really big deal, and the beautiful thing now is a lot of our facilities have access to telemedicine. And so this is a great opportunity for really using that hybrid model. So a lot of times now when I do my birth control, if I do an Explanon placement, then I'll do the follow-up in 4 to 6 weeks by phone to make sure they're fine, and then they can come in later at another time. So really using that hybrid model to decide how you want to engage your patients. I've had more people probably quit smoking because if I set a goal, I can check in with them. You're on 10 cigarettes. When I call you back in 4 weeks, you need to be down to 5. And so really, they don't have to leave work to come in to do that. They can take that call in their lunch break. So really think about how you can utilize your practice model to help your patients. Housing, as I mentioned, that can be a big challenge. The United Way a lot of times has a lot of resources that are available. There are a lot of local churches that have housing opportunities, and again, it's important for you to know what those resources are. And not just for your county. You really need to have a wide perimeter, right? And you need to be the person where, people at church come and say, I have a patient who's in Bleckley County. I know you're not there, but do you know anybody over there? The answer should be yes. So I know the nurse practitioner in probably all the health departments where I have patients that come to me. And so I have their cell phone number. They have mine. So that means if they run into something that they can't manage, they can send them to me. Likewise, I can reach out to them if we have to coordinate care. In terms of the rural component, it gets really interesting, and I think sometimes I know that our nurses and nurse practitioners may feel a little bit isolated, so you need to attach yourself to an OBGYN that you can call. I have a friend that I spoke to recently, I forgot what county, Telfair, and the patient was a Hispanic patient, uninsured, who was bleeding. I was able to do her initial assessment, and we actually were able, she had a really, really big uterus, like almost up to the sternum. And I was able to find a physician in Savannah who was able to help with her care and get her the services. And so you have to become statewide. So the Columbus folks need to know the people in Savannah and vice versa. Like I said, you got to make your friend, one friend. Language, that can be interesting, right? We have a lot of people who are not from here. And so, and even, people with speech or hearing conditions, sometimes that becomes interesting too. And so being able to use your language line or using your phone, or I know a little bit of Spanish, I can say empuja, which is push, I know how to do that. But really getting comfortable with being able to communicate with people is really important. And a lot of times that language translation may come from a family member. That gets really interesting. And so really, I don't want you to be scared of that. I just want you to understand that your job is to break down whatever barrier will prevent you from being connected to your patient. Celebrating is important. We talk a lot about the negative things, but I look at the date of birth and I'll say, oh, your birthday's next month. What are you doing? You have to connect with your patients. And so really take that extra second to do that. What are you planning on doing? Do you have any goals coming up? Are you going on vacation? Anything going on with your mom, or how old is your mom, or something. But again, just finding opportunities for how to connect. Glucose control, Dr. Baker talked about her patients bringing in their logs. Celebrate that when they do a good job. Everybody benefits from positive reinforcement. Do not give them lollipops. Okay? It's not going to help their teeth. But find ways to really support. I have a box of quotes in my office, and everybody that leaves the office gets a quote. It really is replacement theory, because if I've done a pap smear, they probably feel traumatized. But if I give them a quote, they have a positive thought, so they forget that I had to do the pap smear. So figure out your own ways of being able to connect with patients. Milestones are important. You have patients probably who are graduating, getting a new job, new boyfriend. Figure out how to just really incorporate that into your care. Engagement opportunities, we talked about that. And I'm running out of time. I'm going to be quick. I'm going to speed through. So we need to think outside the box. How do we get to our patients? Where are they hanging out? Are they at the grocery store? That's where we have to go. We've got to go to Ingles, got to go to Subway. Wherever you can find them, that's where you need to be. Because really the idea of waiting for patients to come to us is not really ideal. A lot of people are involved in faith-based organizations, really utilizing that as well. If they're doing vacation Bible school, it's probably a good time to go, because they're dropping the kids off. So you have the mom's attention for a few minutes. You give them a sandwich, they probably will talk to you. They let you take their blood pressure, whatever you need to do. Resources. So knowing what you have access to. I have a couple of things that are not on here, like Family Connections, maybe something that you have in your community. They have a lot of things to offer. You want to see what you can do with them. First Steps, Healthy Mothers, Healthy Babies, Zinc Milk, if they're thinking about how to get resources regarding breastfeeding and milk. So I really want us to just be very intentional about that. And again, I'm going to keep stressing, because I work in rural communities. Just because you don't have a lot doesn't mean you can't be connected. But you have to be that bridge for your patients to get to what they need. And I want to end with just respectful care. And it just really is the opportunity where we are very respectful of people. And it's so easy for us to develop our opinions about what people should or should not do, but that's not really our place. And if you think about your job, which I think most of you do as your ministry, you're here to serve people, right? And so it's an opportunity for us to just be kind. And if you wouldn't say it to your mom, don't say it to your clients or your patients. It's not very hard to do, right? Unfortunately, a lot of us have been in the other side of that, where we have received care that has not been appropriate, meaning you can get good care, but the way that it's being delivered is not always nice. And so it's important for us to really change that dynamic and to help make a difference. Maternal levels of care is another opportunity that we're having to really streamline what we do in our state in terms of what facilities can handle what level of patients. And if you do have a patient who has a condition that you cannot handle in your facility, making sure that you have the appropriate opportunity to get them there. Like literally have an accepting physician, but you need transportation sometimes. And so do you have an ambulance? Do you have to call a helicopter? How are you going to get them? Don't put them in your car. That's probably a liability. But my point is, this is an opportunity for us to really think about how we coordinate our care. And you don't have to have everything in your little town. You just need to know if it's something that's outside of your scope, how can you get that person to what they need, and how quickly can you get them there? So that's it for my references. I'm going to leave with my quote, and it just says, you may not be able to change the world, but you can change the world of every person that you interact with. And if we keep that attitude towards taking care of our patients, then I think that we can move the needle a lot more in the right direction. So that's it. I will take a few questions. I know that I'm infringing on time, so any questions, any comments? Thank you.
Thank you so much for everything you do. When you have a patient, what helps you decide about putting them on blood pressure medicine after they deliver?
Okay.
So sometimes
Can you stand up for? Oh, okay, I see you now. Yes, I'm good. My glasses don't work that good. Okay, I'm good now. Yes, ma'am.
So when women are checking their blood pressures like they're supposed to, we do remote monitoring so we can kind of see it. And
Okay.
so if a woman has a blood pressure, what makes you say postpartum, I'm not going to put someone on blood pressure, let's say if their blood pressure is 165 over 105. What would make you say no versus let's try to control that?
So I'm thinking that's not a trick question, because anything 160 over anything is a problem.
Right.
So ideal blood pressure is 120 over 80.
Right.
Okay. Now we use the 140 over 90 to kind of manage the changes that may happen with pregnancy, but I doubt that I would think that there's a case where I would not utilize some kind of medical therapy.
So then who would a woman go to? And then, so a rural community, 45 minutes away. So every time that happens, she has to drive there. They tell her, you're fine, go back. So is it primary care doctor? Is it, who does she go to, I guess, to get medicine?
She needs a new doctor. But so I think if there's a family medicine physician in town, that would be appropriate. But that's a really good question, because I think what happens is sometimes the clinicians that are seeing patients are not as responsive as we would like. And we have to own that. And so that's not me talking about my profession, but we're not always as responsive as we should do. And so in that case, really she's going to have to advocate, and she's going to have to find another provider that can help. So starting health department is not a bad place to start. Sometimes they can manage postpartum depending on what staffing they have. A family medicine physician, internal medicine physician would be appropriate as well. But I hope that's not happening a lot. And so I'll give you my number, and then if you hear of that, then we can work together to find someone that can address that. And we do have telemedicine capacity in a lot of facilities as well. So, but that should not be happening. Okay, I want you to know that's not right. Okay. Mm-hmm. Everyone still awake? Yes? Okay, so if you have an Apple Watch, you know it's time for you to stand. So go ahead and let's do that as we get our next speaker to come on up.
Thank you.